Good morning, everyone. Let the record show that we have a quorum present, and I'm calling the meeting to order at 9 o'clock. And would you please go and bring in Dr. McLaughlin for me, please? Good morning, Dr. McLaughlin. Thank you for coming to the PAC, and we want to question you in your role as Chief Medical Officer. Um, we're considering the report by the Auditor General ensuring quality health care and a healthy population. So I guess we could start if you would try and define for us what the role of Chief Medical Officer is in relation to regulatory functions within the ministry. Yeah, turn it on. You're like green light. You're good.
Good morning, sir. The role for the Chief Medical Officer is it is part of advisory role to the ministry, in contact with regulatory functions, discussing with them, and interacting across the sections of the regulatory arms. There's no formal, like the boards, the regulatory boards, there's no formal position allotted to the Chief Medical Officer, but we try to reach across in terms of discussions once we're made aware of issues, and then the ministry will send me information for input.
Are you familiar with the NHPP?
Yes, I am.
Okay. How does your role assist the ministry in particular in trying to put in place some of achieving the strategies that were laid out in that?
Really, the role should be able to form the functions and inform the strategies, look at them, analyze, look at the steps that have been suggested from the meetings, and see how we can establish monitoring as well as to evaluate how we're moving forward. That would be what would be expected of most chief medical officers, yes.
Right. Does your role lean more to the overall global public health situation as opposed to being more involved in the governance of the HSA?
My role has nothing much to do with the governance of HSA in terms of the HSA structure at all as the Chief Medical Officer. I should qualify that it is a part-time role, and I have a full substantive post at HSA. But for the Chief Medical Officer, that is a responsibility to the ministry. And so it has more to do with the public health arm and the other aspects for it.
Yeah. Does the medical officer for health,
Yes.
who is the person, the kind of line person, as I understand it, who's responsible for that public health aspect of it, do they report to you on a regular basis in terms of the level of achievement in the general health, i.e. like on percentage of immunizations and that kind of stuff?
We have worked since I have started So what we have decided, we try to do is we try to meet each other at least every 3 months to get an update of what is happening. And also if there's something that is going on, like when they had the Zika and the Ebola, we automatically become part of the team. So we have tried to keep, although there's no formal written thing that says this is what you should do, we've decided that after discussions with previous CMOs, this is certainly clearly what should happen. So we have been doing it, trying to do it.
So there is no formal requirement, or do you have an agreed job description for CMO in terms of and how you report that to the ministry, or is it just you have a position and if they feel like calling you, they call in you, or they leave it to your ingenuity to be involved with the public health aspect of it?
Not quite. I think historically what has happened is the CMO has been a part-time post for well over a decade. And so as a result, the general consensus has been to make sure that the work gets done. And the medical officer of health has largely covered that, whereas the CMO has done more with the referral process for the for cynical, because you simply can't do everything in the job description as a part-time and do it properly. So in many ways, parts of the CMO role, as also with the medical director, we kind of have, it has historically been because it was almost like, Dr. Kumar left, Dr. Smith left, so we decided as the younger people coming in, this is what we would try to do within the confines we have and report back to the ministry as we can, yes.
Do you see this position of CMO needing to be enhanced and more a function that should belong in the ministry, where you would have greater opportunity and participation in influencing policy? Because it appears to me that in addition to your regular clinician job as emergency physician, we are being asked to, particularly with the referral systems, again, you're getting into clinical aspects of when a person needs to be referred. And I would think that the role of CMO should be more of a global health policy advisor to the minister and the ministry.
The role of the CMO technically is defined as you have defined it. Within the Caribbean, most CMOs actually hold part of the referral process because you're acting partially as a gatekeeper to try to step away and say this referral is appropriate or not. So some clinical involvement is helpful because it also helps to keep you aware of what is happening and what is in the environment, both in the public sector and the private sector. So that is beneficial from that perspective. But technically speaking, I think as time has developed, the role of the CMO has to, in terms of improving the governance of healthcare, the role of the CMO will have to be addressed further.
Because I think one of the trends in the Auditor General report, it appears that there is that lack of medical expertise and an appreciation for the intricacies of the whole healthcare field, and it appears that there's a knowledge vacuum currently at the ministry level, which in most countries would be fulfilled by the chief medical officer, and I don't think it's sufficient. From the report, it doesn't seem that being a part-time position is achieving the kind of constant monitoring of health policy, health legislation, regulatory facilities that, in my view, should fall more to the CMO?
On a level, I would agree. I mean, I will say that the ministry does, feed me in things to work on, but in truth, there's a limit to how much a part-time person is going to really be able to do all of that. And so it's a reasonable criticism, yes.
Yeah, and in our current situation, as I understand it, and I think the report bears it out in terms of some of the shortcomings that is identified, the medical officer for health as well is now doing more clinical work than administrative and policy monitoring than I believe, and the Auditor General believe is necessary. Is that a fair statement?
I think the difference is he does minimal clinical work because we have seen sometimes the deficit when you become what physicians call a paper doctor, not a real doctor. That sometimes when you get too far from the clinical, it does actually cause decisions that don't necessarily achieve what we're trying to achieve, which is good quality care. So in a small jurisdiction with limited of numbers of people who have that capacity, it is trying to find the balance of what can do that. And I would say both Dr. Williams and myself are at that point where we're trying to see what is the best, recognizing that at the moment changes do need to take place.
Mr. Chairman, through you to Chief Medical Officer. Dr. McLaughlin, in terms of some of those discussions that you've been having with Dr. Jefferson, do you think that there should be a formal place on the HSA board for that Chief Medical Officer as well? Or is that too far out of the remit?
That's through you, Mr. Chair. That's an interesting question. Currently, as it is devised, I think that would be an inherent conflict where, in terms of how the CMO has currently existed, and I'm not talking about myself, I'm talking about the role, the position, because all successive ones have technically been the medical director and the CEO of HSA as their boss. So when you're sitting on the board, there would be a sort of conflict in those things. Because of the clarity, I mean, as it is, I often ask them, who have you invited to this meeting? Is it the ER head or is it the CMO? Because then I can align my roles. I know then what level of authority I'm sitting at the table with. So it is a consideration, but it does require restructuring. For it to happen, it would require a change in how the CMO role is defined.
And thank you for that, because yeah, when I look at the role in other places, primarily in preparing for this meeting, the UK version, and they're talking about them sitting on the NHS board and having, and I don't know whether it's an executive capacity or non-executive capacity, but from a governance model, if at least someone who knows what they're talking about from a practical, a professional standpoint, is they're also guiding the board, even if it's a just on a invitation basis, a normal invitation basis. I would think from a policy and carrying out of things like the NHPP, that there could be the tweaks and interventions as needed, so that some of the things in this report would be addressed in a systematic way. But thanks for that. In terms of the capacity issues at the hospital in overall public health? Like, can you give us a kind of a status quo, meaning what's the situation now? Who assists you? Do you have a deputy chief medical officer? Do you have a team that, you know, when you're looking at public health across the island, some of the things from the NHPP, what kind of assistance do you get in your role is basically what I'm asking.
How the system has been designed currently, the medical officer of health has the primary day-to-day functioning and role for the public health arm. The chief medical officer, obviously, so in many ways, he functions as a deputy for the chief medical officer, simply by definition of the roles of a medical officer of health and a chief medical officer, and the interactions across, and by the law that governs what can happen and not happen. So in many ways, for the chief medical officer, technically the deputy would be the medical officer of health, and that's what has been happening recently more often. The medical director of HSA also, because of his past experience as well, will sometimes act as the chief medical officer depending on, you know, current availability if I am not available. But generally speaking, we're moving more to it becoming Dr. Williams, and then if either he or I are not available for some unknown reason, then the medical director of HSA. So we're just trying to separate that out a little clearer.
Just one more, Mr. Chairman, for this. In terms of some of the statistics that we see, the non-communicable chronic diseases, the heart disease, the high blood pressure, the diabetes, all those things, you know, how involved are you in terms of setting those recommendations up to the ministry and having them come back with, I guess, not a rubber stamp per se, but how are your recommendations dealt with at the ministry level and then disseminated back out to the rest of the HSA and the country?
Well, the primary health care, which is what's largely dealing with the NCDs, the director of the primary health care is also the medical officer of health. So I work with him in conjunction with him, and that's how we assimilate the information up to the ministry and also back down and through him to the public health. So most of that is work he does on a daily basis in terms of the management of NCDs.
The public health law, it has gone through, it's quite an ancient law in itself, right? And it has gone through, it has gone through a number of revisions by the Law Review Commission. There was I think in 2007, there was a committee established to look at rewriting the law to bring it more in line with modern practices. Is there any, do you know what happened? And I know that predates your time, but we're still with the 2002 revision, am I correct?
Yes,
right.
As far as I am aware.
Do you know of any plans by the ministry to review that legislation with the specific purpose of making it more modern to facilitate the kind of things that we were talking about, that we are currently talking about?
At the moment, I am not aware.
Because I believe that part of what comes out in Auditor General report is because of the position you find yourself in as CMO, right? And the medical officer for health often finds himself in under that law, because the CMO is one of those, I gotta be careful of it, one of those, I don't want to call it a dinosaur, right? But it existed at one time, it was chief and bottle washer and everything else. And it has retained some of that expectations with no regulatory or legislative authority, in my view, to properly define its function, which I believe should be more towards policy and that overall review and analysis of what is the state of the health of the country. Do you feel an urgency? Would it be your recommendation to this committee that one of our recommendations could possibly be that there needs to be some urgency in reviewing the public health law and better defining the roles of the medical officer for health, and whether we do in fact need to keep chief medical officer if we do in fact define and give the necessary legislative and regulatory authority to the medical officer of health in that public health environment?
There's certainly a need to look at modernizing the public health law. The presence of a medical officer of health is largely charged with working with specific areas of the public health. Generally speaking, public health is not the only responsibility of the chief medical officer. So there's an overarching responsibility to the health of the nation that comes with the chief medical officer. It has been questioned, but every country has found some other name or something, but they still, even countries that took it out, have brought it back in. Because if you don't have that overarching view, you end up having the silos.
I agree with you entirely, and what I'm trying to get at is that do we need, in your view, do we need to better define and I would proffer enhance and expand the role of chief medical officer in that global view, as opposed to it being something that you think about when you don't have clinical responsibilities to do, which I know from your current role doesn't happen very often in terms of, you know?
I think that looking at the whole, that component of it is, the time has come. I think what has done and what has gone before has done well for that time. It is just that currently the world is in a lot of change and chaos, and we have to change to adapt to be able to get to where we want to be.
Mr. Chairman, through you, can you explain the role and relationship with Cynical, like in terms of your interaction with them as chief medical officer, when it comes to referrals, and maybe just touch on the process that you go through in looking at Cayman's tertiary care center versus overseas care centers, or does it depend on a case-by-case basis?
Through you, Chairman, the role of the CMO for the referrals process is to assign the medical necessity of each referral. So and that's defined within the constraints of the Cynical agreement. So that means that each referral is looked at it on a case-by-case basis, assessing the medical needs of that person in relationship to their requirement. The general process is if the services are available at HSA, that's where it happens. If not, we're locally, then we're tertiary locally, and then we're overseas. So for me, overseas is the last. It's not only just the cost, but people look at me strangely when I tell them we are the only country I know of where it is considered a norm that your care should not end within the borders of your country. And it's been a blessing. I'm not saying that we should not have done that, but we have far more resources available here locally. And I always use the word locally. Every year, every 6 months, something else, some new process that was once overseas, then should be transitioned by right back here if the care is available from that process.
Mr. Chairman, the reason why I asked is that you hear anecdotal conversations about, oh, well, people prefer to go to various institutions. And what I'm trying to ascertain is, does the buck stop with you in that you decide based on the medical need and the resources here and not necessarily the preferences or the leanings to patients and their families? I'm trying to figure out what that, how much of that do you encounter, and if you do encounter that, then what's the protocol in determination, or does that aspect of it, i.e. the patient's preferences, basically not come into play at all?
No, patients' preferences are considered, but it is not the primary component. Like all insurance companies, you may have preferences, but all insurance companies have a limit to what you as the user can do. So the institution usually, unless I think that that institution is the only one that can meet that need, the institutions, because of the financial component, would fall under the remit of the network that Cineco has. Occasionally we will say our medical experience, and if so it is a case by case. So patients' preferences are considered. If it can be accommodated reasonably, yes. If it's an unreasonable accommodation, or if it's a complete breach of the current guidelines, which I function under, then the answer is no. I mean,
continuum of care would be important to that. If the person had already received care at a particular institution and it's a matter of continuing, that would be...
Continuum of care is certainly considered. But at this time, we'll also look at, there's certain factors. The complexity of the care that had to be delivered is definitely going to be considered in terms of continuation. If you have stabilized, become a routine case, and you're only going up every 6 months to say hi to the doctor, then there comes a point where we will say, can I have a medical summary? So we can see, can this, and we now have that specialist on island. Then we can say, well, should we transition the care back home? So continuum of care is a component, but not the final one totally.
Thanks for that, because I guess what I was trying to get at is, do we need, again, recommendations from this committee to beef up those procedures if that was some kind of buttress to that system? Meaning, do you have enough of the parameters in that agreement to hold the line, and your call then kind of is paramount, or
Well, the agreement is agreement. Cineco has written with civil service, and that's the line I function within. So, and it's generally, they're quite Cineco, contrary to popular beliefs, Cineco's coverage is probably the most generous insurance company I've ever seen. So there are certain things that may need to be revisited within that, between Cineco and civil servants, and, with input from the health people arm, because obviously you don't want the decisions being made that don't make any sense medically. From that point, we can always buttress up things to try to make them clearer for the general public, certainly, and even for the people who are working because it does take a little time to understand the system. However, each case is still going to end up, once it comes to a referral, going to have to require, you can never take a patient and not look at them at a case by case. That would just not be good medicine.
Just, Mr. Chairman, through you again, in terms of the outcomes, in the report said that generally we perform well in a lot of the when we're comparing ourselves against the OECD nations, etc. How much of your role then is internationally, reporting and liaison with regional and external countries, just to gather statistics, report statistics, and benchmark the Cayman Islands?
We, the reporting system that has been in place that's currently using, I mean, I have the responsibility to report to PAHO and to CARICOM on the health things. The data is usually collected via HSA. What I think we will certainly need to look at is moving to bring the private sector data through, because it's no longer that HSA is seeing 80% of the population. So as the healthcare field has expanded, so should be the data that's coming from the private sector in to see that. But largely speaking, because of the criteria that are being asked, most of that care is still delivered via HSA. So it is still sound data. I don't want anyone to think I'm saying it's not sound. But I think for forward planning, not for now, it would be helpful to see what is happening in that and it's usually the employed people sector that, in terms of health for the nation.
And I guess thanks for that answer, because I get, when I'm reading this and you see the differences between Caymanian population, expat population, private sector, public sector. My thoughts were that it should be mandatory that all physicians across the island feed up information, because it's only when we get that complete picture that we can really, give more valuable data. I know you said it's still valuable but I think it's time to consolidate that information, because if you're reading this report, there seems to be some recommendations that you have to distinguish, but B, you still have to consolidate that information.
Well, and to your point, we were told yesterday afternoon that they are actually in the process of getting the necessary software to do exactly that and design a reporting system for the private physicians. I guess on a broader, because another thing that runs through this report is there seems to be some disconnect between the private sector and healthcare and the public sector. What is your experience or relationship with the private sector in terms of the being able to influence the quality of the care that they deliver, and also in terms of the economic burden that they placed on you to make these decisions as to where they go locally, right, or overseas, and whether you're getting sufficient information, sufficient support from the private sector to enable you to be in a better position to make decisions that affect them.
I do have some good relationships among the private sector. We did try, and I think it's been demands of time, where we tried meeting with the informal meetings with the CIMDS, the MDC, the CMO, Medical Director of HSA, just informal meetings just to try to improve communication across. Certainly, it does need to improve on both ends, private to public, public to private. I don't think that's, there's no debate about that. That is certainly true. Obviously, as the person who is charged with gatekeeping the referral process, at times I'm not their best friend, and at times I am their best friend. It's the nature of the the beast. And one thing they've, I think, eventually learned, I may say it as clearly as I can, but the information has to be there. And when I say information, the credible medical information, not the other peripheral information or that. But we certainly do, I think, need to improve that acceptance across the borders, that regardless of the general impression, the standards used within the public sector are equivalent to anyone else's standards. Can you find anecdotal cases where it's failed? Yes. But as I say, if you find a physician who's never made a mistake, they never practiced a day in their life.
Right. And that's why we, even after you've been in 20 years, we still refer to you as a practicing physician. The reason I ask that question is because I think that one of the things that leads to this belief, right, that the HSA is just a third-class facility, is the fact that the HSA does not promote itself with all the good things that it does. Because I know that many of the things that other people get credit for, it was your intervention that saved a person in the first place. And all we hear about publicly is the horror stories of the HSA. And I have had this conversation with the HSA themselves, in that they need to find a way to use more of what the private sector is using, in terms of not calling it advertising, but call it informationals, but they're on the radio for 3 hours explaining how good they are, right? And many things that they are claiming as first inventors on the island is we've been doing it a long time, you know?
Yes. What you say is a true statement. HSA is not very good at promoting itself. Some of that, I guess I work for HSA. I kind of understand. Some of it's the mindset of the people who choose to work within a public system. They're more about working. Let me see. Also, some of it is, the volume of patients they're actually seeing is usually more significant. And therefore, at times, they don't have 3 hours to go on the radio. Because if they did that, that's, patients waiting even longer in a burden system. So, but at the same time, the guards are changing. Change has to take place, and probably kicking, screaming, whichever way, we will have to figure out how to actually. And what physicians will always tell you is, but that's my job. I was supposed to do that. What is there to promote about saving a life? That's what I joined. So it is difficult. And when people come and ask me, I tell them the same thing, but that's what I'm supposed to do. What is there to promote about that? So I think it's changing that mindset in all public, but not all, but in the majority of the public people, to realize that people won't know what people are asking for nowadays is a different approach to how you've always done what you've done.
And I think what is happening is that a lot of the improvements or a lot of the additional services that have been available at HSA over the last 5 years to a decade, we're still seeing it as what it used to be 20 years ago, because there is not enough and I don't, promotion is not the right word, but there's not enough exposure to the public of the enhancement of these services that has taken place at the HSA over the last 5 years, for instance. And people, that's why people, what Mr. Vincent was talking about, is that the first choice is, listen, I need to go somewhere else because this is what happened to my mother 20 years ago, and I don't want to fall in that, so I need to go there because they can't handle this. But in truth and in fact, we now have the capacity and the expertise and the personnel to handle many of the things that we couldn't handle before.
Yes, sir, you've said it better than I did.
Well, I am saying it because it needs to be said publicly on TV and on radio, and you all are not in a position to say it, because I think it is a very important, and I think that one of the positive things that can come out of this report is that we have the opportunity now to do exactly what we're doing, is to expose the shortcomings, but get commitments that we're fixing them, but also at the same time be able to give credit where credit is due, and explain to public that, listen, this is not the 1970s hospital that we had. You know, we're far beyond that.
Very far.
Mr. Chairman, through you, again, the K-Health program, we see in the report that it is an example of leading practice, but it's isolated to a smaller group. And in terms of rolling that out to a wider cross-section of the public, and exposing them to that leading practice type program, can you give us any indications of where that is, what's going on with that program, and how it's being disseminated?
Well, K-Health it is a best practice program, and it was really started in the particular group it was, because that's also the highest burden on the expenditure of healthcare per person, kind of thing. And they've done that first cohort. They're starting another one. But I also know they have been looking and working at trying to see how we can spread it beyond just there, and which group, spread it that, because it is a platform that shouldn't matter whether it's a private person or a public person, because it is looking at your standards of health for conditions that we as a nation are automatically at higher risk to have. So it is something, I think it's kind of a little expensive, and so that has been one of the issues they have said. And I presume the expense is in the back end of trying to pull the data out of the system, not necessarily because you're still seeing the patients. It's not like you're going out and recruiting people to come in. This is a part of your normal healthcare.
In terms of specifically page 25 on paragraph 79 of the report, the Auditor General's office asked or said they were seeking to answer those questions. In terms of, again, just your role, how much of those 1, 2, 3, 4, 5 questions would you be advising government on pushing in the HSA itself, and formally responding to those specific questions?
Well, as I said before, the primary care system, currently how it is structured, has the primary care director, who's also the MOH. So the vaccinations and those form largely his direct hand push and plug. I am involved, but more from overall proportion, not sitting there directing it. Certainly we did discuss the and I'm almost afraid to say it because it brought such an outcry, the need for a standard cancer registry, which was created such a public outcry. And I understand all of the concerns the public has, but without it having the things that make it equivalent to any other cancer registry in the world, then you don't actually have data you can report anywhere or data that you can actually say that is credible. We certainly need to look at that. You know, the census does show that neoplasms are one of the primary top 3 killers of our population. We can't get around that. They're certainly talking more and more about these registries for chronic health diseases as a part of trying to understand what's happening within each nation's population. Because those conditions, chronic diseases, and even cancers moving more and more into chronic disease for a lot of the cancers, are what eats a large portion of your healthcare budget, but it also eats into your social services budget. It eats into the productivity of your workforce. It affects every aspect of the nation. So, you know, it is just, if you stop and think about it, that's why they start saying health in all policies, because we just can't get around it anymore worldwide, not just locally.
In the absence of specific legislation for cancer registry, could we not extract some of that information if we did an amendment to make some of the non-communicable diseases, cancer, a reportable disease to the medical officer of health, as we do now with the communicable, with the STDs and the AIDS and everything else? Because I think you would still get a lot more information than you're getting now, and the patient might not see it as so much as their personal exposure, because I think part of the concerns that was expressed to me as a member of the legislative with the legislative framework for the cancer registry was that they didn't want their own personal things out there. But if we required the government physicians and the private physicians to report some of these non-communicable diseases, similar to how we have to report the communicable one, could you not get the data that you're looking for?
Yes, if it still comes with the identifier. The difficulty is and I think people don't understand, the identifier doesn't go anywhere. All that is really used is to ensure, and understandable, patients live between the private and public sector. And so if Dr. X sees them and, they're a newly diagnosed diabetic, and sends the data in, and it's only sent in as a number, but that person's been followed up for his diabetes at HSA, and they've sent in the number, that one person has been counted now as 2, as 3. So I guess the conversations, we are no longer a little tiny, we're tiny, but we have evolved. And the reality is that data goes into a system and nobody sees it, because what is produced out in any domain, even for researchers, is the condition, age, sex. Nothing to do with the person at all. That would never be released out in a public domain like any other registry of anything. It is an innovative idea to...
Because you have to have, with the communicable diseases, there has to be the same thing. There has to be some way of identifying it.
Right. I mean, for anything you have to trace it.
And I just think that...
I just wondered about whether human rights would have a field day with that one.
Well, they probably would, but they are human rights and they are human rights. And oftentimes in this particular field, they cross the line.
They do cross the line, but I mean, no one should be... What we're trying to do is to see how we can monitor patients, how we can keep us healthy, how you don't have your stroke at 50. You're not on dialysis at 45. How can we
and you need it.
Enjoy your life? Because we know that people are living longer, But we're living longer because of better health, but also because of the other arm of health, the one that's most expensive, all of the tertiary interventions. Are we living better quality of life?
That's the key.
That is that's what.
Right? And that is what we want to get to, is that we're not only extending your life, but we're extending the quality of your life, and we're monitoring it. So, but I think I would invite you and the medical officer to look at whether you could achieve what you need to achieve by simply making them reportable disease, as we do with now in terms of getting the information. Because for some reason there's a huge concern, and like you, I know that it should not be that level of anxiety and concern about it, because in truth and in fact, with the information, you're also able to ensure that that person who allowed it to be reported can get a better quality of care.
Yeah.
Because there's continuum and so.
Mr. Chairman, through you, and we also talk about mental health in the report, and the kind of lack of published mental health care guidelines and various protocols. How much are you involved in that in terms of public health? I mean, and tracking people with mental issues, and then their care, or their care after diagnosis.
Well, certain categories of mental health person, their care requires the chief medical officer's approval under the regulations for the mental health law. So I am actively involved in that. In their policies and guidelines that they're working on, not so much. Usually in terms of the clinical data of the policy and the guidelines, the mental health experts are working on that, but they do involve me quite a bit in the involvement. So I am involved from knowing about the institutions that they need, and also simply because I see the ramifications to the country for some of the lack of capacity we currently have in the mental health field.
And I promise this is my final question. I said that about 5 questions ago. But again, in terms of wellness in general and wellness programs, we heard from the chief officer earlier this week that government is making inroads, and they have bespoke programs throughout the civil service, and that they're trying to communicate that prevention is better than cure, and doing regular just wellness exercise and other things kind of assist in the overall health of and well-being of the population. In your role as the kind of public health head, what programs specifically would the HSA or the hospital be doing at this time, and is that something that again should be communicated to some of the patients that you're having to then do referrals, etc.? How much of the wellness comes into your role?
Well, wellness is a part of everybody's role. There are many aspects to wellness, and there's certainly many things that have been done with wellness throughout government and the private sector. What is probably not so well done is the linking of these to try to limit too much duplication. You need a little bit of duplication for choice and also to be effective with it. HSA does provide certain wellness education and in all the different categories. They provide it during maternity, provide it to their diabetics, their hypertensives, general information that is available, and they'll announce these, the smoking cessation that they had on the radio, all of these things. So it goes across to beyond just, because wellness impacts on everyone and you need it all. It's not just HSA alone or the public health arm of government or the Ministry of Health. It requires that. But and I can remember when we were actually discussing the same strategic plan since I was CMO, one of the things that everyone felt was that we know we have a lot of things already in existence. It's how do we figure out to highlight they're there and then scale them up if they need or scale them down because somebody else is doing it. It is that intricacy that often gets, because you actually need a physical body to sit there and say, please go and pull that data, pull that, and that's where it starts to get knocked down into, it's wonderful to sit and think and talk, but you actually need physical bodies to go and do the work. And that's where it starts to get a little iffy.
Is there currently any regulatory review of the effectiveness or the outcomes of all of these various wellness programs that goes on? Are we to the stage where if we get the data, we can predict that there's a longer period for a diabetic before they go on dialysis, et cetera, et cetera? Is there that kind of monitoring to influence policy, or is it just that we know that if you exercise, and don't look at me, that you would be more healthy, right? But do you envisage us hopefully getting to the point where we should have data that we should be able to say to insurance companies, for instance, if a person is involved in this kind of activity, the likelihood of them having claims should be reflected in your policy, and therefore the premium could be lowered?
That's a difficult component because wellness is critical no matter whether you have a chronic disease or not. Activity is important. If you have arthritis, the more you keep moving, the better you are, despite the fact that your arthritis is still going to give you grief in the morning. Because there are many factors that impact on when one person will, and even more than, we know that if you control your diabetes, you delay, exactly whether you delay it by 2 years, 10 years, that is where it gets very difficult because there are other factors that come in, your genetic potential, something else happened, the environment may impact on it. No one knows yet that that environment has a negative component to it. So, but generally speaking, you can look, and certainly you have the data, just as you have the data that obesity increases your risk of having these conditions. Obviously, if you're staying active, you're less likely to be obese. Notice I said less likely because there are other components of obesity. And that's what makes healthcare such a insurance risk. The uncertainty in healthcare exists within it. But if you widen these things across larger populations, you then decrease that uncertainty to a more manageable bit. So definitely, if you can show that as a general trend, instead of where we're seeing high obesity rates in childhood, we know that has gone down, and therefore people are moving more, and these are things that are happening through education, in the diet, through this, through that. So there are a lot of intangibles, but if you can then show that your population, and that's where K-Health comes in, if it's done to everyone, whether you're diabetic or not, hypertensive or not, and you can show that your population's blood pressures are generally staying here, their H1A1C is going there, you then have a more marketable product to your insurance companies to say, you need to lower these programs. As a whole, we are of a lower risk.
And you also need to fund them because it's to your advantage to fund them.
Yeah, well, that's the difficulty. I mean, we all know what to do for for health. We also know that that it's not going to happen without the funding capacities that exist.
All right. Thank you very much, Dr. McLaughlin, and it was very informative, and we appreciate you taking the time to come in. Thank you very much.
Thank you.
Yeah, we'll take a short break because we're